So today I've been asked to talk to you about cognitive impairment due to narcotic use. I'm trying to keep it kind of brief because we only have 30 minutes, but first off, I know you've probably heard a lot about cognition and cognitive abilities today, but I thought it would be helpful to kind of review that and relate it back to, just to highlight all of the skills we're using cognitively all the time, so we really get a good sense of that. Introduce some of the effects of substance use, and then lastly cover some remedial strategies for individuals with intellectual disability, cognitive impairment. So the word narcotics itself comes from Greek, and it means to make numb. So originally the word was used by pharmacologists to describe a very small group of pain-relieving medications. The way I'm using it today, and the way it's more often used, is in the legal context. So any substance that is controlled under the Controlled Drugs and Substance Act here in Canada is considered a narcotic. So to get into the cognition stuff. So some of the things that are being looked at when we look at someone's cognitive functioning are memory, their ability to learn, perform tasks, remember to do something in the future, attention, so all the focusing on what I'm saying right now, switching attention. Executive functioning kind of describes a large group of abilities, so initiating a behavior, problem solving, being able to look at something and think abstractly about options, cognitive flexibility, controlling impulses, self-regulation, gathering and evaluating information, setting goals, planning our day, making bigger plans, right? Psychomotor functioning, so not tripping over this cord, I'm not doing my water. Hand-eye coordination, writing, processing speed, so being able to kind of take in information quickly enough to be able to elicit the right response to that information. Emotional processing, understanding what other people are putting out there and responding appropriately. There's lots that goes into cognition, but I thought I'd kind of make it a bit more real and talk about a little bit, give us some examples of how we use cognition or how it's relevant in our lives. So I have a dating plan, I thought that was funny. Gallery opening, pizza, make out in the park. Someone had to use some cognitive, there was something going on there to make that plan. The center one there, remember to take your meds. So remembering to take the meds is one thing. And then being able to handle the bottle, open it, right? There's that psychomotor stuff. Pull out a pill, maybe they're really tiny pills, right? These are all skills you're all awesome at. We got a lady here who's real upset, looks like, so someone cutting you off in the car. There's some self-regulation happening there, right? Controlling our impulse to slam on the horn or give her the bird or what have you. Poor guy at the bottom, slipping. Toronto was a slippy place this winter. So, just being able to walk and then feeling that the ground under you is a bit slippery and kind of modifying how you're walking. Like that's happening in a millisecond, but we're all doing it. Driving, even without the texting, being able to focus on where you're going and not get distracted by everything around, right? We need to be able to kind of filter all that stuff out and focus on what's important. These are all very complex kind of things that are happening. The top one there, two people kind of holding hands. So again, being able to respond to your children, recognizing that they're sad and then modifying your response to be kind of helpful. Anyone here ever cooked a meal? So much multitasking goes into that, right? Better yet, anyone here a parent? You know what I'm talking about, right? Multitasking. I am good at that now. Just boiling water and then washing the vegetables, chopping them up, right? We're thinking of a million different things and making sure we don't cut ourselves and the phone's ringing, right? There's a lot going on there. And then the pro-con list, whether to buy a dragon or a toaster, right? We can do that though. We can lay it out and say, what are the pros, what are the cons, think analytically about the situation, and then make a decision. So when we talk about cognitive ability, there's lots of stuff, right? So I wanted to talk about, I'm gonna focus on a couple of substances rather. I couldn't go into a lot of them because I have 30 minutes, but these two are particularly kind of prominent right now in the media. I'm sure you've heard of them. Fentanyl is the first one. Fentanyl is a synthetic opiate. The problem with that fentanyl, I mean, it's a pain reliever, and it's really good for treating really severe pain, like in cancer patients, for example. It's used as a patch. But it's 50 to 100 times stronger than morphine. So that's some real powerful stuff. The kicker is that it's odorless and tasteless. And what's happening kind of at the street drug level is that it's being put into other drugs without people knowing it. In order to have an overdose from fentanyl, you need to consume like 3 to 4 grains of salt's worth. So imagine 3 or 4 little pieces of salt. That's how much someone would have to take in order to have an overdose, potentially, or likely. So you don't need a whole lot of it. In 2017 alone, it was responsible for 4,000 overdose deaths in Canada. 4,000, that's a lot of people. In the long term, it's kind of a newer street drug, or it hasn't been used that way recreationally very long. But the risk of overdose is obviously really great, just given how potent it is. It exacerbates, previous mental health conditions. So if you already have something going on, it's not going to make your situation better. The risk of anoxic injury, because what it does is it's a depressant, so it suppresses your breathing. So while you're under the influence, and certainly if you overdose, your breathing slows down, stops, paralyzes your chest muscles. So no oxygen for a while, and you end up with brain injury, right? I know you heard a lot about brain injury and autism, so you've heard a lot of stuff today. Increased risk of stroke, and like many substance use disorders, it can damage personal life, relationships. So there's a lot going on there with fentanyl. And I thought it was probably worth just showing you, if you work with anyone who's at risk or who's using substances, youth, right, buying street drugs, it'd be worth kind of knowing the symptoms, or the signs of an overdose, rather. So, I'm not going to list them all, but lips and nails are turning blue, the breathing's really shallow or not breathing, tiny pupils, cold, clammy skin. The government has recognized that this is an epidemic that we're facing, so now we can get NALOXONE kits. NALOXONE is an opioid antagonist, so it basically blocks the drug from continuing to have an effect on the person's brain. They're free, they're available just about everywhere. If someone doesn't need naloxone, like if they're not having an opioid-related overdose, and you give it to them, it's not harmful, which is why I suspect that the government is allowing people to receive training, and they're being handed out for free to try to prevent some of these deaths. I just took a tiny snippet of the map of like not the best part, sorry, those of you that live outside of this, not the best part of Toronto, but the center of Toronto there. You can see how dense it is, right? So CAMH, where the densest part is there, is where CAMH is. So downtown Toronto is there's a lot of places to get naloxone kits, but they're really everywhere. And the website's really helpful. They have numbers and hours and all that stuff. So that's something that I think is worth looking into if you're working with anyone who is at risk, or if you happen to live in an area where, like I know in Parkdale, there's quite a few occurrences. So methamphetamine was the other one that I thought I would look at, and it's on the rise. It seems that we're getting good at making meth, because they're finding Canadian meth all over the world. Who knew? Australia, Japan, everywhere they're finding meth that's being traced back to having been made here in Canada. So it's increased from, I don't know what it was, but there's a 590% increase in the most recent years in drug offenses. So meth is really prevalent right now in the streets. It's a stimulant, so it's similar to cocaine. And it's white, odorless, bitter tasting rather. It's usually snorted, swallowed, smoked, or injected. And meth comes with a ton of long-term effects and short-term effects. I'm sure you've seen, there was a campaign a few years back with the faces of meth. And you see kind of the change in people, right, when they've been addicted to meth. Some of the long-term risks. Risk of overdose, death. Meth is made of the nastiest chemicals, flammable chemicals. Like there is nothing good in meth. So it's really toxic, which obviously will have an effect on the heart, induce seizures, respiratory arrest, brain hemorrhage. People can become psychotic, impairment of the reward center. So if the part of the brain that is responsible for perceiving pleasure is being kind of stimulated really intensely by a drug like meth for a prolonged period of time, when the drug is gone, the person doesn't perceive pleasure the same way as they used to. So now everything seems to suck a bit more. Now if you add to that a diagnosis of depression, you can imagine what these people are feeling like, right? So you get some suicidality happening at that point. Memory loss, motor skills, language, mood fluctuations, concentration deficits, impaired executive functioning. These things are all affected by methamphetamines. Lots of physical stuff, as I said, because you're ingesting chemicals. Tooth decay, heart disease, lung complications, renal failure. The list goes on and on. It really does. The other thing with meth is that because it's often injected, there's an increased risk of getting HIV or hepatitis, some of these more commonly transmitted illnesses through needles. So it's not good. But you know, so here's overdose. I found this and I thought it was an interesting kind of summary of the overdose situation related to opioids specifically, because that seems to be the crisis that we're dealing with now. So that's the people that die. They use the substance, they use too much, they use that and a bunch of other substances, and they unfortunately pass, and it's tragic. Then there's the people that overdose and live, right? And those are the folks that we work with, sometimes. So again, thinking back to all those different cognitive abilities that you're using them right now. You're gonna know it. Memory, attention, executive function, learning, emotional processing speed, right? Those impairments, a lot of the literature focuses on polysubstance use because I think it's hard to find, or not I think, it is hard to find individuals to study who have done one substance or have used one substance exclusively. More often than not, it's a few different things, including alcohol, tobacco, meth, cocaine, you know, it might be a mix of things, so it's really hard to see which substance is causing what deficits, which is why you see this kind of wide range of impairments. Some may not, for example, have a significant impact on emotional processing long term, but then others will. So I kind of lump them all together. The most significant impairments happen when there's been a medical crisis, right? So overdose, if the person has had a seizure, if they've had a stroke, if they have a brain injury, if they've had a heart attack, those secondary kind of injuries, right? As a result of having used substances, they have this injury now. Those are the ones that are going to cause the most significant cognitive effects long term. Then what if we add schizophrenia to that picture? What if we add intellectual disability, learning disability, dementia, a brain injury, right? These things rarely happen in isolation. There's usually a few things happening. The rate of substance use among people with schizophrenia is like 50%. So half of people with schizophrenia end up developing some kind of a substance use disorder, right? So it's one of those, like, what came first? They have cognitive impairment because of schizophrenia, or is it because they've been using meth for 20 years? Well, who can tell? Same thing with intellectual disability, a lot of these things, right? And just to dispel some myths today, people with intellectual disabilities, the elderly, they all are subjected to substance use disorder, so they're all vulnerable to them. A long time ago, I think there was a misconception that people with ID don't use substances, and maybe they didn't because they were institutionalized rather, right? So maybe they didn't have access to it. But now today, we're finding a lot of folks who either have intellectual disability, was never identified, and it only gets identified, like when they come to CAMH, for example, and are brought in because they have mental illness, because they have a substance use disorder, and then it's flagged as something. We're finding now an increase in the elderly using substances, so this is kind of new, right? So now we're adding that dimension of someone who's potentially going towards dementia, and using substances. So imagine all the different impairments that are happening simultaneously and how much they're all being kind of impacted by each other. So what I thought would be helpful would be to talk about some of the remedial strategies. So remedial meaning we're not looking to kind of permanently change how the person, change the person rather, but how can we help them function optimally? What can we do? How can we adjust their environment? How can we help them reach their full potential, right? So visual reminders is a big one. Signs, step-by-step instructions, labeled drawers, calendars, phone numbers, appointments, audio reminders. We have these really cool books at CAMH. Has anyone here ever heard of cognitive adaptation training? Yeah, it's usually used, one person. It's usually used with folks with schizophrenia. It was developed for people with schizophrenia with cognitive impairment. But it uses all these kind of strategies, right? So we're big on CAT at CAMH. So we have all these alarm clocks, and what you can do is you can voice record, like you can record your own voice. So instead of me telling the person to get up in the morning, it's them telling themselves to get up in the morning. They can record it and be like, hey, don't forget, you got that doctor's appointment today at 9. And then the alarm goes off. Instead of buzzing or playing music or whatever, it says, hey, don't forget, you got that, right? So it's, again, towards independence, right? It's always about giving them the tools so that they can be successful, given their limitations. Visual information, so labeling hooks. I find this helpful for my husband as well. This is where the keys go. So if you don't know where the keys are, just look at the key hook. And that's where they are. Oh, I'm so glad you're awake. All right. So things like that, right? It's so simple. It doesn't sound like a lot, but really, it goes a long way to helping someone move through their day efficiently and feel successful at something, right? Mark food with expiry dates. So if the person's living on their own, they may not be great, again, at attending. They may not look in their fridge after they do grocery shopping and say, okay, what do I gotta take out of here? Now this is green and moldy, and they may not be doing all those steps. So labeling things to make sure they don't eat something that's really old, or the food doesn't come, or the fridge doesn't come full of rotten food, right? Little kind of tricks and tips around how can we support them better or differently. Whiteboard with the date and the season, weather. A lot of these work for across the board, right? It doesn't matter what the etiology of the cognitive impairment, whether it's a brain injury, intellectual disability, dementia, related to substance use, schizophrenia. It doesn't really matter why. It just depends what the individual needs, and that's what it comes down to, is that individualized support. Keep written information clear and simple. So I used to work in group homes a lot, and you go into group homes and you see things like the date or whatever, and it's great. But then it's like the date, and then there's like flowers around and rainbows and like leprechauns, and there's just like all kinds of like fun, lively stuff, which is lovely, but confusing, right? So keep it simple is my recommendation. You know, the date should say the date. All that extra stuff, if you think about all the deficits and someone's inability to tease away what's the important information I'm looking at here, you want to remove all that unimportant information. If it doesn't add value to what you're doing, don't add it, right? Like that clock picture, I wanted to show you the clock picture, but the rest of the remedial slides, boring. Like there's no pictures whatsoever, because there was no value in adding pictures, right? See, boring. So, remove distractions. If you're having a conversation, if you're trying to give them information, if you're trying to teach someone something, if you're trying to get information from them, just think, look around the room. Are there lots of, is there a light that's kind of flickering over there? Is there a distant alarm clock going off? Can we close the door? Can we clear all this stuff off the table, right? These are all distractions. If you're already kind of impaired, these are going to be barriers to you being able to effectively listen, process, understand. Like there's going to be glitches here and there, so you need to remove all those things. Give frequent breaks from tasks. I recently spoke to someone and they said, she about a client with intellectual disability, said, she can only stay in class for 45 minutes. It's so frustrating. And I thought, oh my God, 45 minutes is huge. I can't stay in a class for 45 minutes. So, just bear in mind, if the person looks like they're getting fidgety, time for a break. Don't wait for them to start getting upset and telling you to, bugger off and telling you they're leaving. If you sense them getting, restless or what have you, hey, I have to use the washroom, so why don't we take a break, right? Allow sufficient time to process requests and questions. Sometimes you just gotta sit there and, it's more uncomfortable for us than anything else. So just be uncomfortable, just ease into the discomfort. All about the acceptance commitment therapy. Sorry, I already said that. Arrange the environment in ways that encourage success. So as I said, hooks by the door, right? If there's like a coat hook and a key hook, you're increasing their chance of not forgetting their keys by 100% by kind of arranging things smartly. Teach them how to prepare kind of low effort, inexpensive meals, for example. This isn't by no stretch exhaustive, by the way. I can talk about this for like days, but just in the interest of keeping it simple and brief. Repetition, right? We all need repetition to learn. Repeat things, information as often as possible, as needed. Practice skills, do role plays. I challenge any of you to read a book on how to do heart surgery and then do it effectively, don't kill the person, right? Reading stuff, knowing stuff does not change behavior. They have to do it. They have to feel what it feels like to say the words, to do the actions, to put on the coat. So get them to practice. Make it fun, get in there, have fun yourself. Praise and encouragement. I'll get into that after. Emotional support. If you're not sure how they're feeling, ask. So I work with, majority of my clients in the forensic system have schizophrenia, majority, or antisocial personality disorder. So, one thing about schizophrenia that's very common is the blunted kind of affect, right? So happy as a clam, but they're just like stone-faced. I can't tell heads or tails. What's happening for you? So I ask, your face looks really angry right now. Are you angry? Is that what's happening? Or in that way, that kind of tone, that very kind of inquisitive, I really just want to know because I want to know whether to leave you alone or to continue speaking to you. So if you come at it from that kind of angle, if you don't understand what they're feeling, just ask. Are you feeling angry, happy? What's going on? If you don't think they get what you're feeling, then just tell them. Right? The trick is how you do it. That's something that you can't teach enough of, I don't think, is like that, those interpersonal skills, working with any population, especially people who are adults, especially people with cognitive impairments, who are stigmatized, who feel less than, who have had some really nasty experiences. I have a few, just a few more tips. They're not remedial strategies, they're just from my brain. When in doubt, assume the individual that you are supporting is not able to perform the behavior rather than simply refusing, right? So consider the deficits and the barriers first. Hospital charts, especially psychiatric patient hospital charts, are riddled with non-compliant, refusing to engage, not engaging in treatment. These are all words that sound like the person doesn't want our help, that they're basically giving us the finger. And to that I say, no, I doubt it, right? Like more often than not, there's a deficit there. There's a reason that they're not engaging. Maybe we're not making it accessible to them. So I think we need to always consider that first before we jump to, well, they don't want help, or they're refusing to come to program. They don't want therapy. They don't want to change. And don't they? Maybe they do. Praise, acknowledge all successes, regardless of how small. So those of you that are parents, this will be familiar. Remember when your kids started learning to speak? And they started reaching for something? Like imagine this is a ball, and they're like going to reach for it, and you say, what do you want? Say ball. And they just look at you and go, bah! And you're like, good job, here's the ball, right? They didn't say ball. It's okay, because it's it's closer, they're like a step closer to saying ball, right? So think of our clients that same way, not like children, because they're not children, but think of these small steps as successes and acknowledge them as such, right? Hey, you didn't do all that, not yet. You didn't cook that whole meal by yourself, not yet, right? You will one day, but not today, and that's okay. Be aware of your own biases, your body language, your tone of voice. It's really, really easy when someone has so many cognitive deficits to start talking to them like this. It's really easy. I've caught myself explaining things, like over-explaining things, or speaking a little bit too slowly. So I think we need to catch ourselves. We need to be aware of the fact that we're talking to adults, and despite their cognitive deficits, there's a way to communicate and that is respectful and still doesn't make them feel bad. Be patient some more, and then add a little patience to that, because it do take some, right? It takes some patience to work with people in general, but especially when we have some sad stories, we have some clients who are difficult to work with sometimes, we're probably difficult to work with sometimes, so we all gotta be patient with each other. If you don't know how you can help the person, then ask them. And if they don't know how you can help, then ask a professional. So that's my final thoughts to you. After that, I have a couple of, there's a few slides that you'll get afterwards, I understand, with some referrals, kind of information for CAMH services, and some references. Thank you.